All right, we'll go ahead and get started. So thank you for participating in the i2i Center's virtual spring conference. We're pleased to offer you this session on expanding access to technology-based care solutions, making the case for adopting innovative technology solutions that combat clinical and financial challenges in healthcare. We have a few notes for you before we begin. So today's presentation is live, and although you are seeing us on the WOVA platform, this is a Zoom event. And so in order for us to see and answer your questions, we'll need you to submit them through the Zoom Q&A feature, which you should see down on the bottom right of the screen. So please do not use the WOVA chat to the right for your questions, as we cannot see that. You are welcome to submit questions throughout the session, and then we will take them all at the end. So if you signed up to receive continuing education credits or contact hours when you registered, we have a quick request. Please type in your name now in the WOVA chat box to the right on your screen. Then at the end of the session, type in your name again into the WOVA chat box. And this will provide a timestamp for your attendance and a backup log for AHEC. The WOVA system tracks attendance, but in case there are any technical problems, this will be used as a backup. The session is offering 1.5 hours of general continuing education credits from Southern Regional AHEC. Registrants who signed up for CEUs with registration should have already received an email with from i2i with a link to set up your AHEC account. This is required for you to receive the CEUs. Note, license-specific continuing education credits are not available at the conference. And to qualify for CEUs, you must attend the entire session and complete an evaluation for each session. CEU evaluations will be sent to you by Southern Regional AHEC. Please be aware, CEUs can only be earned for sessions you watched live during the conference, not for sessions you go back and watch at a later time. For those not seeking CEUs, we want to get your feedback also. To complete the evaluation, go to the WOVA agenda, find this session, open the page and scroll down till you see the Rate Session button. Click and complete your evaluation. All right, so those are all of the notes for you, and we are going to go ahead and get started. So Rachel, if you can go to the next slide, that would be great. The objectives for our discussion today are to understand how traditional healthcare regulations create challenges to adopting telehealth services and how policymakers can implement policy changes to promote adoption of innovative telehealth solutions. We will learn how disrupting traditional thinking about technology for patient engagement can close gaps and improve well-being, as well as avoid unnecessary ED or inpatient admissions. Rachel and Kathy will help us understand how health plans use clinical and financial data to assess new initiatives and innovations. And then finally, we will learn how to make the case for implementing telehealth solutions to overcome the challenges that patients have in accessing care. Rachel, next slide. So before we get started on all of that, we'll take a few moments to introduce ourselves. I am Michealle Gady. I'm the founder and president of Atromitos, a consulting firm based in Wilmington, North Carolina. We specialize in health and human services, policy, strategy, operations, contracting, and marketing and communications. We are an all virtual company with team members throughout the US. Our mission as a company is to create healthier, more resilient, more equitable communities. And we do that through the work with primarily public insurance programs, providers, and social service organizations. I am a lawyer by training. I have specialized in health law and in particular in the public insurance programs. I've had a varied career starting out in nonprofit advocacy roles, representing beneficiaries through their appeals processes and advocating Congress and the administration on policy changes. I've worked for multiple members of Congress on major pieces of legislation, including the Medicare Modernization Act and the Affordable Care Act. And then after leaving DC, I entered the world of consulting. And I say I did that mostly as a means to satisfy what I call my professional ADD. And basically what that means is I just like to work on complex problems, unwind them, and then find a path forward. which means I do a lot of work in public insurance programs. So I'll turn it over to Rachel now to introduce herself.
Thank you so much, Michealle. I'm thrilled to be here talking to you. I know you did welcome us a couple years ago into the state of North Carolina, and so we're just thrilled to be back here. Good afternoon, everyone. My name is Rachel Jacobson. I am the Executive Vice President here at Pyx Health. We are a solution that solves for loneliness and social isolation for vulnerable populations. We have been doing this since 2017 and are currently live in over 20 markets across the country, including North Carolina, a state that Michealle led as actually one of our first outside of Arizona. And so we are thrilled to be here to share with you the impact and what we're seeing in the partnerships and how really bringing loneliness and social isolation to the forefront as a chronic condition to solve for is incredibly important in the impact that we're having. So really excited to be here and share this innovative approach. And I will turn it over to Kathy.
Hi, good afternoon, everyone. I'm Kathy Oestreich. I am happily retired. I currently serve on the Pyx board. I did have 40 years of healthcare leadership experience prior to my retirement, with over 20 of it on the provider side and just about 20 on the managed care, Medicaid, Medicare side of the business. As a leader, as many of you know, you're always having to look and find creative solutions to reaching vulnerable populations and supporting the needs that are vast and varied among the ages, demographics, and geographic distribution. So I'm thrilled to be able to be here today and talk about our experience with Pyx. And I'm currently a board member serving on the board of Pyx Health. Thank you.
Thank you, ladies. All right, we can go ahead and get started. Rachel, thank you. So technology in healthcare has a long history that has evolved over time. Primarily, it's been leveraged by clinicians through advancements such as X-rays or MRI machines or medical lasers. In the early 2000s, we saw a wave of technology improvements through electronic health records, which theoretically allowed for better organization of patient data, and then again, theoretically, made that information easier to share between clinicians. Telemedicine has long been an important tool in ensuring access to needed care, but I think we can all agree that since March of last year, the availability and use of telehealth services has certainly exploded. And in response, we've seen rapid policy changes at both the federal and the state level. So technology and healthcare innovations are natural partners, and each is interdependent on the other for future growth. While the technologies we've all become most familiar with exist primarily to enable clinicians to deliver healthcare more efficiently and to more people, we have seen over the last few years a growing use of technology focused on enabling patients to meet their health and well-being needs where they are and when they're ready to do so. And this trend is driven in large part by mobile technology, and in particular, mobile applications. We see this as a revolutionary opportunity that can place patients in the driver's seat when it comes to the management of their own health. But it brings with it certain risks, and balancing between the two represents a challenge for regulators, for patients, providers, and other stakeholders in the industries. So as a result, our regulatory environment, including what can be paid for and how, has not really kept abreast with the advancements in our technology. So Rachel, next slide. So when dealing with complex issues like technology in healthcare, it is imperative that we all speak the same language. And so to borrow a rule from Voltaire, let's start at the beginning and define our terms. And so when I talk about telehealth, I am using that as an umbrella term that encompasses a variety of telecommunications technologies to deliver health-related services and information. And this is distinct from telemedicine, which is specific to when medical information is exchanged from one site to another through telecommunications technologies for the purpose of improving a patient's clinical health status. And this is often known as remote clinical services. So Rachel, next slide. And so you may ask, are the definitions and distinctions really that important? And yes, they are. At least when it comes to important details such as regulatory requirements, whether it's reimbursable by insurance, and how and when it can be delivered. And those are determinative details when it comes to adoption in the healthcare delivery landscape. Oftentimes, innovations are not going to be adopted if there isn't a way to receive revenue for it, or if it doesn't have some sort of financial and clinical impact. And so, for example, Medicare has traditionally imposed restrictive circumstances on when and where telemedicine can be reimbursed. This restrictive application has been a primary obstacle to the wider adoption and therefore standardization of telemedicine. So whether a service or modality is telehealth or telemedicine can carry different rules or standards or eligibility for compensation. And since telehealth services do not have to be clinical in nature, this means a wider range of professionals can offer and be involved with those services. And as a result, they are generally defined differently than telemedicine. This means they may or may not be reimbursed by insurers. And so a really great resource for understanding the different policies and regulations, the laws, and how things do and don't work is the Center for Connected Health Policy, which serves as the National Telehealth Policy Resource Center. Next slide, Rachel. So continuing with the theme of let's define our terms, let's talk about synchronous and asynchronous communication. And so synchronous communication requires that both the patient and healthcare provider be present at the same time through the use of a telecommunications platform that permits real-time interactions. And these are your virtual visits. This type of interaction generally does not require the parties to be in any particular location. Asynchronous communication, on the other hand, does not require the parties to be present at the same time and may never result in a patient to provider interaction, though the option to communicate with a provider must be available. So if you've ever used a mobile application that guides you through an AI-run screener, resulting in recommended next steps, but not direct communication with your healthcare provider, you've used asynchronous communication. Asynchronous communication can also be known as store and forward. So the initiating party is entering and uploading, which means storing, the information in a platform that is then sent, read, or forwarded to the receiving party to review and act on when they are able. This use of asynchronous communication is used often from provider to provider consultation. So when a primary care provider, for example, is working with a specialist, or when receiving lab results from your provider through your patient portal, that is also asynchronous communication. So next slide, Rachel. And then just two more modalities for you to know. The first is remote patient monitoring. And through this modality, a device is used to remotely collect and send data to a healthcare provider. So perhaps a home health agency or a testing facility. And the purpose is to keep track of certain vital information for the patient, such as monitoring blood glucose, heart ECG, or even for falls. And then the next modality is mobile health or mHealth. And this is what most consumers are familiar with. It's a mode of care that includes monitoring and sharing of health information via mobile technology, such as wearables and health tracking apps. So next slide, Rachel. So my perspective is that technology further enables patients and communities to direct their healthcare, to take charge of their health and well-being is in fact a great leveler. And in this time when we are realizing the great disparities and inequity we have in our healthcare system, looking at innovation and health technology is one of the ways that I think we can address some of that. When implemented and used properly, there are numerous benefits of telehealth. Just to name a few: expanding access to care, the ability to reach more patients when they need it. So delivering care to patients on their schedule versus when the provider is able to book an appointment, improving health equity, and then improving, of course, the patient's engagement in their own health. Next slide, Rachel. So let's talk about a world pre-COVID. I'm not sure if anybody remembers that world. I'm not sure that I even do. But pre-COVID, federal Medicare regulation really serves as a guidepost for telehealth reimbursement in our healthcare system. And the narrowly construed definitions impose limitations on where telehealth services may take place, both geographically and by facility, as well as what services are covered. And specifically in non-emergency times, so in the olden days, 2019, under federal law, Medicare reimbursement for telehealth services was really only available when the service originated from an allowed setting, which is limited to a clinic, a hospital, or certain other types of medical facilities, and that originating clinic, hospital, or facility is located in an officially designated rural health professional shortage area. So basically, only in very limited circumstances did federal Medicare allow the setting to include a patient's home. So the public health emergency was really the first opportunity for widespread use of telehealth services in Medicare beneficiaries' homes. And while that may seem hard to believe based on our current experience, prior to COVID, telehealth was primarily viewed as a means for actually expanding the provider network. And so when specialty providers were needed for consultation, the patient would go to the primary care office, which is the originating site, for the visit, and then the specialty provider would join remotely from their office, which is the distant site. And this context shines a light on the really paltry utilization of Medicare telehealth services prior to COVID. So only about 14,000 beneficiaries received Medicare telehealth services in a week prior to the public health emergency, as compared to over 10 million beneficiaries that have received a Medicare telehealth service during the public health emergency from mid-March through early July of last year. So then as it relates to Medicaid, while many states will follow what Medicare does, states do have the option to determine whether to utilize telehealth, what types of services to cover, where in the state it can be utilized, how it's implemented, the types of providers that are qualified, who can deliver, who can be paid, and so on. And then in a state that uses Medicaid managed care, telehealth reimbursement can also vary from plan to plan. And so state Medicaid and other payers generally model their telehealth approaches after Medicare, which makes it really important for us to establish policy at the federal level, because it does in fact have that ripple effect. Next slide, Rachel. And so again, it's at this point, it's common knowledge that the flexibilities enabled by the federal government at the start of COVID have prompted what can only be called an atmospheric jump in telehealth use. And so in response to the COVID pandemic, by way of congressionally approved emergency powers, CMS has enacted policy changes to expand payment for telehealth services and to implement other flexibilities so that it allowed patients to continue to receive access to care while remaining at home and avoiding exposure to the virus. And I'm not going to go through all of them. You guys do have these slides, but some of the important changes to Medicare telehealth policy are summarized in this table. So next slide, Rachel. So let's talk briefly about what's happening in North Carolina. So Medicaid and CHIP through the public health emergency are reimbursing and permitting the use of two-way real-time interactive video and audio. Services must be provided over a secure HIPAA compliant technology with live audio and video, such as through smartphones, tablets, and computers. Virtual communications are also permitted, and this can be done with technologies other than video, such as audio and secure messaging, but HIPAA rules also must be followed. Next slide, Rachel. So what are the barriers to the use of telehealth innovations in healthcare? We do expect that the public health emergency will end, and many of the flexibilities that have been put in place will likely go away. And so we'll be returned back to those pre-COVID times when there were significant barriers. And we group them into three categories. And so the first is really lagging regulations. It's not a problem that's unique to telehealth or telemedicine. I'd say across the board, technological advances in healthcare are outpacing and outgrowing our existing regulatory framework. And when it comes to telehealth, there are a few further complications, and that one of them is in fact the scope of practice. So with the exception of CMS regulations, primarily relating to Medicare, how healthcare is delivered and more specifically, who can deliver what services is governed by state statutes and regulations. This leads to barriers and inconsistencies when practicing across state lines. The policy landscape for providing telehealth services includes licensure and practice standards, and there are 50 sets of them, often in conflict because they are set by each state. Further, providers are required to hold a license from the state within which they are practicing. So in the case of telehealth, this is where the patient resides. And state licensure laws were first enacted in the 1800s with the intention of limiting competition and protecting geographic markets. So today, these outdated policies limit access to care and act as a barrier to one of the most significant benefits of telehealth, which is in fact connecting patients and providers at a distance. So the Interstate Medical Licensure Compact was implemented in 2017 to streamline the licensing process for physicians practicing in multiple states by allowing qualified physicians to complete just one application and separate licenses from each state in which they intend to practice. With 29 participating states in the compact, this does reduce the administrative burden for physicians, but really does not resolve the barrier to the practice of telehealth. This is further compounded by the fact that variation in scope of practice has in complicating the implementation of telehealth and telemedicine is the fact that it's a highly contested issue, particularly in states that continue to require nurses, including advanced practice nurses, to operate under the supervision or collaboration of physicians when providing medical care. So that tends to lead to further legislative inertia as it relates to clarifying ambiguity where there are overlapping practices, scope of practice. So where any tweak to statutory language is perceived as high stakes political wrangling, much needed amendments, updates, and clarifications are often they're kicked further and further down the road. And so progress in supporting the regulatory framework for telehealth delivery ends up becoming collateral damage, and we don't make the progress that we need to. So lack of standardization, this is our second category of barriers. There is certainly a lack of consensus around the definitions for telehealth and telemedicine, and while earlier I seemed very certain in my definitions, that was me being certain. This variability is not just definitional though. It represents how telehealth regulation and policies have been developed and implemented in a piecemeal fashion over time. And so the degree of confusion that persists as a result of that doesn't help with bringing us to standardization. To illustrate the exponential impact that comes with having 50-odd regulatory frameworks as opposed to a single federal framework, consider the fact that each state sets its own policy for what constitutes telehealth service delivery, specifically determining what services can be delivered remotely, by whom, and under what circumstances, and what is eligible for reimbursement using state dollars. To illustrate the limitations this imposes, consider a startup company developing groundbreaking technology, and rather than being able to quickly get it to market, they must spend countless months and maybe even years assessing state telehealth policy and adapting their product to each state, and frequently for each disease or professional intervention in each state. This creates an administrative burden on providers and telehealth services operating across state lines, but also represents significant headaches for providers who operate within the state. This lack of standardization really does get even worse depending on the scope of practice that you're talking about, because each practice also has their own professional standards. And so in addition to trying to make the technology work in these different markets, providers are trying to figure out how to sort through the myriad regulations to understand what they can and cannot do to implement innovations in their practice. And so until recently, namely with the passage of the CARES Act and certain CMS policy changes, many providers reasonably felt that the benefits really were outweighed by the burden that came with it. And so now we're not picking a fight about state autonomy. We recognize and laud certainly that states individually are often better able to identify and legislate to address their specific needs. In our federalist society, states can serve, and you guys have heard this phrase, I'm sure, as a laboratory for innovation. And this is evidenced in no small part by the innovation that actually comes out of the Medicaid programs. And I think, Rachel and Kathy will certainly give you an example of that. But nonetheless, highlighting the impact that the lack of standardization is having on the adoption of telehealth really is important, because we really do need to find a way to standardize our regulatory framework so that it really allows for the growth and the potential that these technologies have for patients and for providers. And then lastly, the final category of barriers I'll talk about is the lack of parity. So the subject of telehealth parity is certainly not new. There are existing parity laws in 43 states in the District of Columbia that require commercial insurers to cover telehealth, but the coverage parity is not the same as payment parity. And so the latter requires insurers to pay for telehealth and in-person services at equal rates. And while we may have coverage parity, we don't necessarily have payment parity. And in fact, only a few states have payment parity laws for telehealth. Now, though, with the public health emergency and the rapid expansion of telehealth, we are seeing more states focusing on introducing and putting in place payment parity for telehealth. In addition, telehealth payment parity for the Medicare program was recently discussed at a congressional hearing and in the Medicare Payment Advisory Commission's recent report on telehealth. So the issue of telehealth payment parity gained national attention when CMS used its waiver authority to establish payment parity for in-person video and audio-only telehealth during the public health emergency. And as is almost always the case, commercial insurers follow suit. You'll often hear commercial insurers say, well, we don't pay for it because Medicare doesn't, or we pay for it in the way that Medicare does. Commercial really does follow Medicare. But it's unclear whether payment parity will continue after the public health emergency and for what kinds of telehealth visits. So in fact, CMS has already announced that Medicare will not cover audio-only telehealth for evaluation and management visits after the public health emergency, and may decide to pay for telehealth visits at a lower rate than what they were paying during the public health emergency. So next slide, Rachel. So those are the categories of barriers that we face. And where do we go from here? Well, we're going to need congressional action. And while I know that sounds like an oxymoron, I do think we will see forward progress, at least on some of the issues. We do know that the waivers that have been granted by HHS cannot be continued once the public health emergency ends. And so we will need statutory changes at the federal level to allow some or all of the current flexibilities to continue. Fortunately, and not surprisingly, states are taking much quicker and more expansive action than the federal government is at this time. There's more than a dozen states that have already moved to codify some of the pandemic's telehealth rules. And in fact, the American Telemedicine Association has called this their most successful year that they've had in 3 decades. So recently, the group scored an important victory in the state of Texas, where lawmakers passed legislation permanently allowing Medicaid to cover telehealth. And that legislation allows for audio-only services, addressing, because there are such extensive concerns about broadband access across the state in low-income and rural parts of the state. And so while this is great progress, we really are going to need action at the federal level. And so, our call to action is for stakeholders to take this really important opportunity to weigh in with both federal and state legislators and advocate for continued flexibilities in these areas, because they really do improve patients' access to care. And providers have seen significant benefits in terms of, fewer missed visits and things like that. So I will leave you with our next slide, which is just a short list of some resources that you can access after. our discussion. And I will go ahead and turn it over to Rachel and Kathy.
Thank you so much, Michealle. I learned a ton about telehealth myself, actually, so I really appreciate that. So thank you. We're going to talk about one disruptive way that Kathy's former Medicaid health plan, while Kathy was at the helm, was using telehealth in this really innovative and impactful way. So when we think about the objectives of our next sort of 45 minutes together, one is we'd love to think about disrupting traditional thinking about technology for member engagement in order to focus on whole person applications. And I know that that terminology gets thrown around a lot in healthcare, and we really do mean whole person here. And we'll talk about, the space between the clinical and the non-clinical that we're helping solve. And the impact of that is that we are proving to close gaps in care and really saving managed care organizations unnecessary ED visits and hospitalizations. Not only the amount of the visits and hospitalizations, but the cost of when one of the members that uses our platform does use the ED or hospital is actually a lower cost than someone that's not, which is important. I think using clinical and financial data to assess new initiatives around what is the strategy of thinking about social determinants of health for my members and thinking about transportation and some of that intensive navigation that plans want to do, but don't often have the resources to do. And then how do we implement telehealth solutions to overcome the challenges to accessing care experienced by your patient populations? And oftentimes it is not that they don't want to receive care. It is often that they don't know how or where to access it. And so helping members and your patients get access to care in whatever way is best for them, is most accessible, is really important. So before I jump into the research, I do think it's important to give a little bit of an overview of Pyx Health. Some of you may have seen my CEO was supposed to attend. She could not, so I'm stepping in. This is actually her second company. The first one she had sold to a publicly traded organization, but this one is a passion project from a family member suffering from behavioral health and addiction and crisis. And many of us in this audience know that all too well. And it was really our passion to connect with folks that are unable to reach out. And I'll talk about some of the science of loneliness in a moment, and make sure that we are supporting them in whatever they need. And as managed care organizations, taking on the responsibility of helping members, this is one way to think about that. So we've been in this market, I mentioned, for 4 years. 95% of our book of business is made up of the Medicaid and Medicare payers, mostly Medicaid. So we feel very strongly about Michelle's passion for the public insurance marketplace. And that's where we've dedicated our time, our team's time, and our resources. Do you want to say anything, Kathy?
No, I think you're doing great there, Rachel.
So let me talk for a moment why managed care, why healthcare organizations, why providers should care about the subject of loneliness. And it's so interesting. I had someone tell me pre-COVID, actually, Rachel goes out and beats the drum of loneliness across the country until people listen. And pre-COVID, pre this public health emergency, executives were interested and not taking action. Post-COVID, we have all experienced individually loneliness and social isolation, and it's more, it affects our members and the cost of healthcare much, much more than just it's the right thing to do and our members need support. So a couple of reasons to take away of why loneliness is important to focus on. One is that it's incredibly pervasive. This is from 2018, the AARP, more than 1/3 of adults in the US are lonely. The most recent stat I read was over 60% of Americans are now identifying themselves as being lonely. Secondly, it's incredibly deadly. There have been lots and lots and lots of articles on the health impact of loneliness. Dr. Julian Holt-Lundstad is incredibly famous for this wonderful clinical trial she ran showing that loneliness is actually the equivalent on someone's health in smoking 15 cigarettes a day. It also increases someone's risk of mortality by 45%, and it's more dangerous to someone than obesity or alcohol use. And then finally, Members that suffer from loneliness have different patterns of utilization across the healthcare system. This is a study done back in 2019 in Dallas County. Parkland Health and Hospital actually looked at 80 Medicaid members that had used the emergency room more than 5,000 times in a year, costing them about $14 million. They interviewed all of these patients, and loneliness came back as the #1 factor for these emergency room visits. And we see this over and over again. And it's not just an overutilization, there's also an underutilization. And that's where that access to care case objective really comes into play here. And you may be sitting there thinking, Rachel, this is great, but how come I haven't heard about loneliness before? And it's really that the science around loneliness is incredibly new. And to be perfectly honest, the US is pretty far behind the rest of the world in considering this to be a chronic and important epidemic within our population. The UK has a czar of loneliness, so does Japan. And so this research that I'm going to share with you all, and you have the slides so you can access the full studies down below, is as new as 2019. And so really our mission is to get out in the world and share this with folks so that healthcare organizations and executives understand the impact. And so here's a very high level overview of the science of loneliness. When someone is chronically lonely, it triggers this fight or flight response within the brain. And that has a whole host of negative effects. I also want to share, I should have first shared, loneliness is subjective. So, social isolation is actually a physical condition of not being around other people, but you can be surrounded by groups of people and still be lonely. It's a subjective experience. You can see in that first bullet, defined by someone's satisfaction with their connectedness or their perceived isolation. So when someone is lonely, their body goes into this fight or flight and the cortisol level rises. Not only does it have a whole host of negative effects on the cardiovascular and the central nervous systems, it also rises someone's white blood cell count. But it also has impacts within the brain patterns. And so someone that is lonely actually develops, that second bullet down, a distorted reality of the social world around them. They misread facial expressions or your tone of voice. They can send signals of distress because they're in this fight or flight, elevated cortisol level response, causing others to withdraw or impacting their ability to be social. And what's happening in someone's brain is a very unhealthy cycle of reclusion. In very basic terms for everyone on the phone, someone who's lonely, their brain is on repeat going, I'm alone, I'm lonely, I'm alone, I'm lonely. And so they can't actually reach out. We may be sitting there thinking, why can't they just call me? It's actually impossible for them to call you because they have this mental cycle happening in their brain. So they need help to embrace solution approaches. And those solution approaches can be telehealth, telemedicine, care management, any type of support that you may be offering folks. If someone is lonely, they actually do not have the ability to engage there. We have got to solve the loneliness first. And so I'm going to hand a couple slides. Kathy and I are going to ping pong along the presentation. So hopefully keep it interesting for the remainder. Thanks everyone for staying with us. And Kathy's going to talk a little bit about the Banner Health ecosystem and really, what solving for Pyx was. We have some overview of statistically significant case studies and impacts of this. And just as a reminder, please throw your questions into the chat and we will ensure to save the 15 minutes at the end to engage with you all. Okay,
Great, thanks, Rachel.
I think real quick, sorry for clarity, she meant the Q&A, not in chat.
Sorry, I'm so sorry. Thank you, Michealle. I forgot there's multiple platforms. The Q&A button in the Zoom. Okay.
The video meetings are awesome.
Yeah.
Until technology steps in. So just before I jump into the Banner and sort of our life cycle of solving for loneliness, I think Rachel raised a really important point. And for any of you that have ever witnessed this in a parent that's aging or a parent that loses a spouse or anyone that loses a significant other, that their perception of loneliness is real and pervasive. And I watched it firsthand prior to COVID as my mother went through the aging process after losing my dad. And she had people around her all the time, and her constant complaint was she was lonely and she was isolated. She was with help, but she wasn't in a social situation that she found valuable. So I think that, and then when we hit COVID, I think we all had that aha moment when we've been sitting in our family room or living room or kitchen table for a week on a computer and realize you haven't talked to a human being that isn't in your house. And as that went on, I think we all became really aware that this is not an isolated situation, that this can affect anyone at any time. And so I think as time has passed and as we went on our journey with Pyx, it just continues to be reinforced that this is a solution that we as healthcare leaders and we as members of society should continue to keep focus on and really try to understand what we can do to support people, sometimes in the most simple ways. So when I retired from Banner Health, and talking about Banner Health, some of you are probably really aware of them, some may not be. Very large health system, primarily in the West. In Arizona, it is the largest private employer in the state. Significant number of acute care hospitals and clinics and urgent cares. They have their own hired physicians. And so they drive the quality of healthcare delivery and the innovation in the market. There are many great institutions in the Arizona market, but Banner's size alone and their commitment to building quality processes and workflows and things that drive consistent performance have really set them apart in the market. Banner also went on the journey about 10 years ago to start one of the first ACOs, and some of them you may remember from the Pioneer ACO days. They cut their teeth on taking that risk and understanding how to manage patient populations. About 8 years ago, Banner purchased the University Physicians Healthcare, which included University Health Plans, which was an established Medicaid plan since 1985. It had been a statewide plan for much of that time. And over the last 7 years, Banner, in addition to the traditional Medicaid and the Medicare D-SNP, added a long-term care services product. And the state of Arizona went to full integrated physical and behavioral health in 2018, which really set in motion the need for new thinking, because we had had a segregated system for so long. And as the state looked to integrate it, they wanted something new done, not just piece together the parts of the two, but come up with something new. Go ahead, Rachel. So what was our challenge? The challenge for Banner University Health Plans was no different, or Banner Health Network, no different than it is for most people. The high utilization of Medicaid members, of long-term care members, of the Medicare special needs population. If you're looking for complex populations to challenge your ability to not only drive quality, but control cost, these are the folks. And every state has a very significant percentage of their population that fits that description. We know from history, and I told you how long I've worked in healthcare, but we're also finding it was difficult to really quantify things like the impact of case management. And over time, while it's really important to have those personal touches of a care or case manager, they also have a limited reach within the members' circle. And so while we tried a lot of things, not all of them really drove results, and results being both better outcomes and lower cost. As stewards of taxpayer dollars, all of us that are in this Medicaid space know we live to a high standard of using those taxpayer dollars in the best way possible, providing the most healthcare possible. So as we went on the journey, and as Arizona started to talk about an integrated physical and behavioral health plan structure, and we took on the long-term care population, I had a conversation with Cindy Jordan, the founder, and we were talking about the fact that these populations are largely homebound or home and community-based. They're living in various levels of supported care. And the behavioral health component is such a high percentage of people with Medicaid and Medicare. And so what were our options? And Cindy had been noodling on an idea that looked to support people in their space, in their circle, at their time. And as Rachel mentioned, really leading, or coming from a place of personal experience. And as we looked at technology, there's a lot of immediate reaction to technology doesn't work for these populations. But the state of Arizona really put the challenge out to say, health plans, you have to figure this out. You need to look at technology as a form of member engagement. The other thing about why Pyx Health was the drive and passion for solving the problem, a commitment to really continuing to move the platform until it fully served the members. And as we learned in the early stages, adding a human care team was really an important part of the Pyx Health model. And we could serve many more of our members in a much more comprehensive way, considering with using a technology like Pyx Health. And we did evaluate other technology, but this is the one we landed on. And as Rachel mentioned, and we'll talk more in detail about the results, the initial analysis has been positive throughout the transition or the launch period into active use of the product. Next slide, Rachel. So I already talked about the technology and human combination. The chat box in Pyx is one of the most compelling pieces of the technology, because the chat box interacts with the members in a way that a human being does not. Certainly a call center person will be kind and helpful and outreach with the member, but to be there when the member needs the most, a chat box can do that. Typical automated programs, push notifications, push information, we didn't find to be terribly effective in serving our populations. But when the member could interact with something like the chatbot, it changed the whole conversation. And it then provided 24/7 access to support for the member. And Rachel will go into more detail about the model that has evolved into really an impressive way of managing member need 24/7 and focusing on the social determinants of health. We took this conversation into the health plan, into clinical leadership. And while there's always a level of skepticism going into these, everyone recognized there had to be another way to do it. And loneliness and isolation was literally eating our lunch when we looked at these highly complex populations. So how do you do this successfully? And I would say this applies to any technology, not Pyx specific, but absolutely any technology. And it really was who in the organization is going to own it, and having lots of ambassadors and buy-in. I was very fortunate to have our clinical leadership be very excited about looking at a technology. And they were, as clinical leaders, very actively involved in supporting the development and learning with Pyx, the Pyx team, about what was going to work for the members. The challenges were initial member engagement. We tried all the usual methods, and eventually we found that the most successful way was to actively person-to-person engage. And the Pyx team did that. They reached out to the members, they met them where they were at, whether it was in a phone call, in a home visit, but how did we get them onto technology? How did we understand their phones? They all have phones. The common conception that Medicaid members don't have phones or Spanish-speaking members don't use phones, those simply are not true. And it was really a matter of getting them comfortable with their phone and the technology that could live on that phone. But one of the things that I think was really exciting about this, and I think speaks to everything we've talked about previously, is really that the early feedback and member testimonials, we were listening, and all of a sudden we kept hearing the word friend. And people that were our highest, most complex members, who hadn't been out of their home in weeks, hadn't gone for a walk, didn't take their medications regularly, were really in a fully supported situation of needing full support, started talking about Pyxer as a friend. He's somebody that makes me laugh. He's somebody that's there when I need him. He reminds me to go for a walk. He reminds me to take my medicine. And we weren't expecting that. We were expecting they would use the technology and they may their health may improve. But this idea of friendship, I think drove home this idea of loneliness and isolation is real, and everyone needs a friend, even if it's a little chat bot. And we initially went into this, as I said, with a behavioral health integration plan on the horizon, was really thinking, how can we touch our members with depression and anxiety? But really what surfaced is those are underpinnings or symptoms of loneliness and isolation. So the four, kind of taking all of those in a perfect storm, you have a very complex mental and physical health situation with the member. And we were pleased with how well members adopted the Pixar environment.
So let me give you all just a very high level overview of the platform itself. And it's really built on these three tenets, which I'll go into just in a little bit of detail. I think at a very high level here, one is we've got to get this in the hands of members that need it the most. So you may be sitting there saying, how do I even find members that are lonely? So we'll talk about how we do that. Secondly, as Kathy alluded to, we use technology, and that is Pixar, our sweet, compassionate chatbot in the bubble. And he really helps to build what one of my colleagues calls trust equity between the member and the organization. And I would say it's hard to do that over telehealth or over video or over, an application. And we'll show you how we tackle that. But I think for any type of telehealth solution to be successful, there has to be trust between the patient and member utilizing it and whoever is on the other side of that interaction. And then finally, while technology is incredibly important to scale this and to be a 24/7 accessibility for folks, we also know that at its very core, loneliness is human. And so we couple the technology with human beings, and I'll talk about how that interacts. So really quickly on the intentional delivery, these are some of the populations that our plan partners and Banner had focused on when rolling out this tool. And the way that we roll it out is actually our organizations and partners give us lists of members or populations, and we can apply a logic to them, or we can just call through those lists. We take on the burden of enrolling folks from the organization and calling and walking members through, as Kathy said, how do you use the technology with the application? And actually one of our partners in North Carolina who serves primarily SMI and members suffering from homelessness, pre-COVID actually did a pilot where they rolled out iPhones to very high risk members, specifically suffering from homelessness. And we had preloaded the platform onto the phones, and then we would call those members and enroll them in the tool. But we also taught them how to use the phones at the very same time. And it was incredibly successful. Many of them engaged for a long period of time within the platform. So you can see a little bit of the buckets of folks. One thing I would say that is crucial in targeting loneliness is to find members after some sort of transition of care or a healthcare event. I would argue that COVID is a healthcare event for almost everyone. It affected everyone differently. But thinking about a vulnerable moment for someone when they need a little support, or frankly, thinking about someone in your life where something has happened to them, be it a clinical event, a stroke, pneumonia, an onset of a behavioral health, that's when they need support. And that's really when the Pyx platform should be introduced to folks. We serve a lot of high-risk pregnant moms. As you can imagine, that's an event. Becoming pregnant can also be incredibly lonely. So just one population of many that we focus on intentionally delivering to. I just want to show you a little bit of the technology, mostly to share that we are non-clinical. And so we fall under that mHealth definition from Michealle earlier, in that one of the goals of Pyx is to understand how someone is feeling on a day-to-day basis rather than their disease state or diagnosis. We are not a covered entity. We want to leave that to the providers, but we do want to engage with folks. And so this idea of building connection and companionship is the vehicle to getting the member and patient engaged. And then we can take them to a whole host of places within the healthcare system. And so the user can tell the robot how they're feeling, and that will inform his chat that comes to the user. A couple of things to note: there's no free chatting in our platform with the robot, and that is for liability purposes. It is all modulated to the population. So Pyxer will talk differently to a 65-year-old Medicare member than he would to an 18-year-old, with SMI, differently than he would speak to a 35-year-old, Medicaid member. So it modulates to the end user. It's also available, of course, in English and Spanish for folks. And one other piece about, I would say, telehealth in general, that I know wasn't part of this, but the whole access to broadband and Wi-Fi is an incredibly important component of telehealth. And I know Michealle and us align and feel very strongly on this. We serve vulnerable populations. And so what that means for us as a company is that 90% of Medicaid members have smartphone, as Kathy alluded to. That's no longer, an issue. However, only 50% of them on average have Wi-Fi. And so members are, living on their data plans. It's really important to think about that even when you're talking in your organizations about telehealth and telemedicine access. But for us as a company, we don't do things like push video links to our vulnerable populations because the perception is that it eats up data. It is in the App Store, but it's also available through any web browser because many folks might not have an email address or a credit card. So I would just urge you to think about some of those broadband issues that affect our populations when we talk about access to care and specifically access to telehealth and telemedicine. Of course, we have to talk about social determinants of health. My CEO likes to say, when you shake the tree of loneliness, all of these other needs come out. So if loneliness is the vehicle through which we are engaging with members, they are then sitting in the car with us, sharing everything that is coming up for them because they're in a safe, trusted space. Whether they share that with the robot or with the compassionate support center, it's really, we don't care as long as we're learning about things that members need. So we screen monthly for social determinants of health. These are life events. They should not just be screened, once a year. I know we all strive to do at that as a minimum, and that is challenging. But if you can get to folks, especially that, need that to understand what it is that you need daily. We also will integrate, specifically in North Carolina, of course, we've integrated with the NC Cares 360 platform, so we can push resources to members, not only through the tool, but also through our Andes and compassionate support. One other thing that's very interesting to us, and we see this over and over again in all of our managed care organizations and partners, is that members that have an SDOH need tend to utilize the platform at a minimum 3 times, at most 5 times or more, longer than members that do not have needs. That means, loneliness is pervasive, and if we're not engaging with members that are lonely and understanding what they need, we can't support them. And so this is a good sign for us that people that are in need are engaging with the tool. And then finally, our last tenet, and then I'll hand it to Kathy to talk about our statistically significant white paper case study. And I think we'll be right on time here, is that we couple this technology with human support. So the technology provides that 24/7, the screenings for not only SDOH, but loneliness, depression, anxiety. All of the conversation is geared towards CBT and self-management. And that's the goal, right? How do we help people self-manage and get access to resources on their own? And then, of course, and this isn't, a full demo, but I don't believe any technology should be standalone within the ecosystem of what an organization is trying to do. And so we allow plans to connect to other health plan resources within the platform to give members, sort of that one-stop shop of understanding, if I'm trusting the chatbot, but I need to talk to the suicide hotline or the 24/7 nurse hotline. So that's also very important to us. The human component, we're allowed to, it allows us to support members in a more human way, in that kind way. It also allows our organizations, for their care managers, case managers, nurses, and providers to operate at the top of their license. As Kathy mentioned, they are strapped for just time and bandwidth. And so let's let them operate through those clinical KPIs, let our team take on the burden of companionship. We support urgent SDOH needs and any other needs that members have. Unfortunately, the public health emergency has upped the level of acuity that we have seen through the call center. So we have, called mobile crisis teams in 911, and members have told us, I don't know what I would do if somebody hadn't reached out, even though there's someone else in their house. We send back referrals, and then our call center is 7 days a week for both inbound and outbound. So based on a member's interaction in the tool, scoring lonely, talking to the robot at 2 a.m, the SDOH resources button is actually our #1 most used resource between 12 a.m. and 5 a.m. We will actually make outbound calls to folks. When we talk to them, they need one of two things. Very, very often, they need that direct connection back to the planned resource or to a telehealth provider. We can do warm transfers. We can walk them through how to access the telehealth or telemedicine platform that you all may be offering. And that's really important too. Sometimes it's not that people don't want to use it, it's that they don't know how to access it or how to actually engage. And so our staff can help folks do that. And then, of course, that's all reportable. And then, of course, we do the companionship calls. And this is really where our Andys are licensed in some way. They are full-time employees of the company. They are overseen by a licensed behavioral health provider. Many of them are LICSWs or peer support certified. We see about 60% of our members are going to speak with an Andy at least once after onboarding. Of these members, 61% told us that that interaction helped them avoid a higher level of service defined as an emergency room visit, ambulance ride, or a crisis intervention. And then, of course, we are tracking a decrease in loneliness. And so we see 80% of our users have scored better on the UCLA 3 after 2 Andy calls. And so let me turn it to Kathy. Of course, we've been in the market 4 years, but this is a really study near and dear to us. And I think it's important, Kathy, to note that Banner had utilized Pyx in the middle of the bid through 2018. And so this case study was done independent of our team, solely done by Banner Health data scientists. We had no input, partly for their own information, and then also partly to show the state the impact that the technology they had written into their bid was having.
Great, thanks, Rachel.
Yeah.
And I think that Rachel's raised a lot of great points on just this journey of understanding how loneliness and isolation is impacting our member populations and how and where technology can be very helpful and almost necessary in today's world. One of the things that we had to be able to talk about, as you know, nobody wants to talk about money, but everybody has to talk about money, right? I mentioned earlier, stewards of taxpayer money. But one of the things that for myself as an executive, I always had 2 burdens. One was to get the clinical leaders to buy in, and the other was to get the corporation leaders to believe in what we were doing. And so everyone was bought into the idea that this was a complex population and we had to solve for it. And through the bid process and integrating physical and behavioral health, the bar went up really high to try to figure out how to do that. But it also went up from the perspective of leadership anxiety about what could go wrong. So one of the very early discussions we had with Pyx is, we were the early adopter. We came in and have been on that journey for those 4 years now or 3.5 years with Pyx, and have watched the evolution of the tool. But we also knew throughout that process that there had to be a way to show savings. We wanted our members to feel connected and supported, but we also knew if the connection between loneliness and isolation was real and depression and anxiety were real, then there had to be a cost saving somewhere if we were finding the right points in the members' care to intervene. And as Rachel said, we purposely started dialing in on people that were transitioning out of significant health events, inpatient medical, inpatient behavioral, a trauma, a big ED visit, some type of thing that really created a situation for the member where they were going to be subject to being isolated. What we pushed on hard was to say we've got to have data, and it has to be scientifically validated. It isn't going to be okay for Kathy to stand up in front of anyone and say, it's great, we saved all this money. And so what we went into very early on was the understanding with the Pyx team that we were going to do this analysis. And as Rachel mentioned, we have Banner, we were fortunate to have our own data scientists, and they built a control group model. And we started looking at 6 months post Pyx utilization claims data, and that work, there is a published white paper. I think it will be shared with you after this presentation. that work has continued, and that data continues to be updated on the run out. And as members come on and off of Pyx, what is the impact Pyx is having? The initial 6-month study was that there was a median savings of $5,083 per member. Now that wasn't per member per month, that was per members on the Pyx platform. That comes out to $847 a month savings over a 6-month period of time. I can tell you that the reduction of inpatient stays alone more than covered the cost of Pyx, but people were still skeptical. They were still, well, would they really not have gotten better anyway? By creating the control group, we really then were able to evaluate the behavior of people on Pyx and people with the exact same cohort of conditions that were not using Pyx. And so that data has continued to be updated, and it continues to support this level of savings and greater. And that they are absolutely continuing to see a reduction in ED and inpatient services for people using Pyx. Another question is often, how long will members stay on Pyx? And early on, and it continues to be true, that the average time of use, the initial time of use was 68 days. I think what's equally important is that members return to this app when they're struggling again. And it took us a while to know that, but they return to the app when they're feeling isolated or lonely, or they have some social determinant of need, and they look to Pyxer to help solve that for them. So it continues to be something that is, the humanness of it is creating a great stickiness for the populations. And these are, as all of us know, these are the hardest members to attach and engage, because they have so much more going on in their life than just simply taking care of their health. Next slide. So adoption was another big concern. You know, we've all talked about the myths and beliefs around Medicaid members and technology and Spanish speaking and English speaking, and all of these things were swirling around. And what we learned early on was that we sent targets for benchmarks for enrollment, and 40% were actually enrolled in the Pyx program when given the opportunity, far exceeded any of our prior experience, which for most of us, I think we'd say in the 14 to 18%, we're pretty darn happy if we can get that level of engagement. So at 40%, we knew we were onto something. And by population, because again, a lot of beliefs that Medicare members won't use it because they're too old, and Medicaid members won't use it because they don't have technology. And the reality is, again, we set a target rate of 20% conversion, and we exceeded it, and continue to monitor that by population. And they all continue to have these similar results. And so at the end of it, you remember early on, I mentioned that we were looking at all of our case management models, evidence-based medicine, all the things that every one of us have spent our careers looking at and trying to find secret sauce. And what we found out, and continued data continues to support, is that this type of telehealth intervention, and Pyx in particular for Banner University health plans, has proven itself to be invaluable in supporting these complex populations. And I'm going to turn it back to Rachel for some closing remarks.
Kathy. I just want to end on this slide to share with you all. I mentioned that Pyxer does sentiment tracking within members. And so one thing we have spent a lot of time studying over the past 4 years here at the company is, what does a lonely member look like? It's not as easy to diagnose as a COPD, condition where you can go in and understand, or some clinical test. And so what we see in members that suffer from loneliness is they use words to Pyxer in the emoji wheel, such as worried, in pain, and sad. Most of this occurs from late nights, so 10, 11 a.m. until 5 a.m. 2/3 of our members that suffer from loneliness have an SDOH need. On the flip side, a lonely member, we have those that use the tool that are not lonely, that just enjoy the interaction, and they find it to be, frankly, an easier way to access the health plan resources. Use words like hopeful, content, and happy. They are most often active during the day and early evening, sort of what you would consider to be quote unquote baseline normal hours for utilizing this tool. And only 1/3 of them have an SDOH need. And as I sort of wrap up, I want to share in the summary points, but I hope all of us can take a moment to imagine what that lonely member feels like. We've all felt worried, in pain, and sad. These are what our members are suffering from when they suffer from loneliness and then utilize. It's not a great way to be. And so we want to help people get out of that. I think in summary, we believe that members suffering from combinations of loneliness, behavioral disorders, emotional distress, and/or sleep disturbance are high risk of avoidable, unneeded utilization. It's clear to us, and it proves in the data, that 24/7 access and engagement is critical. And frankly, we need technology, and that's where Pyxer comes in. He's cost effective and scalable. And 24/7 nurse lines are, available for this need, but they're incredibly expensive. You're staffing them with nurses, and they have not historically been used by members in the middle of the night. And ask yourself, if you're up at 2 a.m. and feeling sad, are you thinking, man, maybe I should call my plan's 24/7 nurse hotline? It's just not the first thing that comes to mind. And then finally, Banner Health, since that study, and actually before that, has expanded its use of Pyx Health to its entire Medicare commercial ACO lines of business, as well as its ACO. And so the next step is really to use a study around a difference in difference methodology. I want to leave you with one more member study. We have 3 minutes. It'll take 1 minute. I know we're going right to the time, which was the instructions. I mentioned we serve pregnant women. Parkland Health Plan, that study I showed earlier in the presentation, is a current client of Pyx Health, focusing on high-risk pregnant moms. They are a plan that has an equally active English and Spanish speaking population. And we just pulled their data yesterday. English and Spanish speakers utilize the tool the same, equal amounts. We've seen, a 58% reduction in loneliness in that population of being pregnant and lonely. And one member story that is sticking out to me, it was a 27-year-old, Spanish-speaking pregnant mom who utilized the platform for just around 40 days with an average of 44 interactions. She talked to Pyxer daily. She used the coloring book, which is another feature. She utilized our Compassionate Support Center 3 separate times. In the last loneliness screening, her loneliness had decreased. She had started with mild to moderate depression, and that went away in the PHQ-2 screening we did. And then the last thing she told Pyxer was that she was content. And I just want us to think about any other technology where someone is utilizing 40 days in a row every day. It's longer than a lot of treatment plans, getting the support they need, utilizing the center and hopefully improving their mood, which is hopefully going to improve her whole pregnancy and that. So, loneliness is not a senior problem. It spans generations and classes and ages. And so hopefully we've demonstrated not only how important telehealth is to getting out access to care, especially with folks that may not be able to see a provider, but also thinking about how do we support other conditions. Personally, for us, we think loneliness should be number one through telehealth and other means of scaling that. So let me pause my screen here. And I had one question shared to me, and then Gary, you can let us know if there's others in the chat. I'm going to read it so I don't mess it up. As individuals become more emotionally connected to technology, how do we ensure we protect against security breaches and assure trusted professionals are involved with the robot? I'll take the question from Pyx, and then Michealle, I don't know if you have other thoughts on just telehealth security in general. From our standpoint, first of all, we are we're almost high trust certified. We're an incredibly secure platform. None of our interaction with the robot is stored on the phone, and it is all directed decision tree based. So there is no ability for members to type anything into the platform. They are selecting answers as they go. So as we think about, security breaches, we hold ourselves to the high trust standard. And again, we hold national contracts with almost all 5 of the top national Medicaid payers in the nation, and their security is, sort of the top. And so we are incredibly diligent and focused on being secure and impactful to members, sharing that data in a way that is meaningful back to the plan. And so there is no trusted professional on the other end of the robot, but there are trusted professionals on the other end of the Andy Support Center. We put them through trainings and de-escalation, crisis management. And so we ensure that they are trained and ready and fully supported from our standpoint in order to interact with your members, just like you would expect your care managers to be. Michealle, I don't know if you want to add anything on.
I'll add a couple of things. You know, the HIPAA security and privacy rules are out there for, you know, these kinds of reasons. And I think that they play a role in ensuring that we are protecting against security breaches and that we are trying to minimize any potential harm to the patients that are using these things. But we also know that there is a lot of room for growth and improvement as it relates to security protections. Healthcare is without question a major target for malware and breaches and so forth. And so we've seen that there are a lot of security breaches for health-related information. The 2020 report estimated that 71% of mHealth apps have at least one vulnerability that could lead to a data breach. And so there's just a lot of work and diligence, and we also need to change regulatory framework in order to ensure that the requirements are put in place. If you know, it's sort of like if the law's not there, there's not that push to make sure that code is done in a particular way, that there's an ongoing security process in place, that, you know, staff who are on the other end of the app are using it, but also that patients who are utilizing the app, there's a need to engage and educate them so that they understand what their role and responsibility is in protecting their information. So it's definitely an area that companies do try to, you know, ensure the most secure private environment that they can, but it is an ever-changing environment, and companies just have to be diligent in staying on top of that and not getting lax in those practices.
Mm-hmm. Let me end on this contact slide. Gary, I think there's another question if you want to come off mute and resume share that with the group.
Yeah, there was a comment and question saying thanks for the fantastic additional info and insights about loneliness. And going on to say that since individuals and families are encouraging the use of telehealth and telemed solutions, and that we've seen the positive impacts during the last year, how can we help to continuously improve the process in this innovative field? So for folks on the phone, what can they do? That's kind of maybe to both of you guys.
Michealle, do you want to take that one first?
Sure. So, you know, in healthcare, continuous quality improvement is paramount to ensuring that we are operating in the safest, most effective environment, and that we are constantly evolving to ensure that we are meeting our patients' needs when and where they need them. I believe that the application of the CQI process in the use of technologies like this is absolutely appropriate. You know, the example that Kathy gave us, that Banner right from the get-go had a plan to study the intervention and are evolving that study process to continue to evaluate its effectiveness. I also just happen to know that, you know, through this data, you know, Pyx has been able to take that and make changes to their processes to, you know, respond to what the data is showing in order to move the innovation forward. And I don't think any of that changes, you know, whether you're talking about a traditional healthcare intervention or an innovation in healthcare in the use of technology.
You want to go?
Michealle, I couldn't agree more. And I think what I would probably add to that, as far as, you know, continuously evaluating what everyone is doing about and thinking about in their approaches, I think there's a couple things, and I say this a lot, is first of all, people have to have an open mind, and Rachel and I can tell you, and I'm sure Michelle can, we still run into an awful lot of healthcare bias, an awful lot of belief systems that have been baked into taking care of Medicaid or taking care of Medicare Advantage the first thing we all have to do as leaders is back away from that and work with our teams and educate our teams on loneliness and isolation and all the interactions, and where technology is not a threat to them or their position or their intellect, but it is an adjunct to them. It gives them an extension into those members that they could never humanly possibly meet. But I think constantly challenging one's thinking about it and believing that things are possible, because as the owner of the company or founder of the company would say, we took a flyer, we did, but it was that conceptually we believed that there had to be a solution to work on this problem, and that historic technology just wasn't where we felt it needed to be. So I just can't stress enough, I think the open mind, challenging your teams, your clinical leaders to really be brave and think broadly all the time about what is possible will allow you to get down this path and find that there are tremendous resources today, and you can start influencing the resources of tomorrow by being a willing adopter and engager in technology advancement.
I would just add, call someone. Just call someone and say hi today that you haven't talked to in a while, or that may need a little bit of a reach out.
Mhm.
So I have a couple others going back to the beginning with Michelle's conversation. This one says, Michealle, you spoke in detail about the policy and payment challenges that are barriers to the broader implementation of telehealth. Are there other population-specific challenges that providers and payers need to consider when implementing telehealth applications for their patients or members?
Yeah, I think we've touched on a few of them. Kathy has made the point that the Medicaid population and the Medicare population, they have smartphones. And the data out there definitely demonstrates that. But what they don't have, as much as, for example, a commercially insured population, are laptops, desktops, or tablets in their home. So technology interventions that are platform limited you need to pay attention to those kinds of barriers. So if understanding the technological capabilities that your target population does have, because they will have them, you just have to understand what they are. So broadband access within the home is definitely another area. Beyond affordability, there are just places, particularly in North Carolina, where, I've been driving through the town, and then I take a left, and I am now in a neighborhood where there is no broadband. Full stop. They don't have it. So even if they wanted it and could afford it, they couldn't have it because it doesn't exist. So there is, in North Carolina, lots of legislative activity to try to expand access to reliable broadband, and those initiatives and legislative objectives exist in other states. So making sure that we are advocating for policy changes that don't just say, okay, telehealth is covered, has to be covered at the same rate, and these clinicians can do it in these circumstances. We need to look at policy changes that also ensure that the folks who need to use them will have the capability to do so. And then kind of the last note that I'll say is, in Medicaid and then of course in Medicare, beneficiaries will have potentially cost sharing obligations. With an intervention like Pyx, they probably don't. But if you're looking at an intervention that covers, primary care type services or other types of interventions, they may in fact have a cost sharing component to that. And we do know that, lower income, marginalized populations tend to be what is called unbanked. And so they do not have at the same rate as, the general population access to and use of electronic forms of payment. And so when we are looking at technological interventions to implement, we need to understand and accommodate any cost sharing implications that may exist. And so the technology vendor may all of a sudden need to implement a billing process where the individual can access the service without having to input a credit card or debit card of some sort, but they can be later billed. Because it's not a matter of just simply waiving that cost sharing, because again, there are federal laws that make that potentially illegal. So those are just, at a high level, understanding the technology modalities that your target population does have access to, assume they have access and understand what it is, addressing limitations to broadband within your communities, and then really thinking about if there's payment attached to the use of the service, how are you going to handle that for individuals who cannot pay with an electronic form of payment? Rachel, Kathy, anything you'd add?
No, I'll just confirm,
Yep.
Michealle, we do not charge the member or ask for any form of billing. And it's one of the reasons we built the progressive web app, because we realized the stores to download the platform was a barrier to folks that not only might not have a credit card, but might not have an email address, which is required to access that. So thinking about how do we remove barriers to entry to the marginalized and vulnerable populations we've been working with is incredibly important to us. And I think you bring up a really good point.
I agree.
And the very last question refers back to the policy change Michelle's referring to, and just are there specific agencies or organizations that should be engaged by providers and payers that are trying to advocate for this?
Absolutely. Obviously, your legislators at both the state and federal level, but don't forget about, particularly in state, your Medicaid agencies, your departments of insurance. Those are regulators who may already have existing authority to make regulatory changes. They just need to have the motivation to do so. And so when you think about your advocacy approach, it needs to be kind of both legislative and administrative, and really thinking through making your case for why expansion and access to these types of technologies are important. I kind of hate to phrase it this way, but this concept really cannot be minimized. Is in the United States, we have a pretty deep culture of convenience. And so really thinking about the convenience factor when people need to access care. I mean, I'm not calling my primary care provider at 2 o'clock in the morning. I'm not going to do that, but I can engage with Pixar. Right. I'm not going to call my care manager at 2 o'clock in the morning, but I can use an app like Pixar to find a social determinant of health need that I need to address. So really thinking about that culture of convenience and what that means for access and utilization, and then what that means downstream for not just process and outcome measures, but actually improving the health and well-being of communities. And so I really do think if you start to think about it in that way, we can make progress. Rachel, Kathy, anything you'd add?
No,
Very well said.
Yeah, perfectly.
That's all I have.
All right. Well, thank you, everybody. We have exactly 1 minute left. I hope that you found this informative. If you have any questions, our contact information is up on that last slide. Please do not hesitate to reach out. Rachel, Kathy, any last comments?
No, thank you so much for having us. And as Michealle said, please don't hesitate to reach out with questions. We greatly appreciate you all being with us today, and what is a very important issue and topic as we go forward and thinking about our healthcare system. So Michealle, thank you so much.
Thank you. I appreciate that. For those who are here for CEUs, please don't forget to type in your name as we conclude the session.